So it was just a few days ago that I was given the extreme privilege to be a speaker at the inaugural Hospitalist and Resuscitationist Conference in Montreal, Canada. And this is the first of a number of talks that I gave entitled, My Patient is Blue, What Do I Do? So I'm going to present a case that I'll use as a common thread throughout each of the 5 talks that you're going to hear. Rather than going through an exhaustive differential diagnosis of hypoxemia, I'm instead going to give more of a clinical mechanical approach to certainly work of breathing and hypoxemia, because hypoxemia is a key driver of work of breathing. I think this approach is appropriate because it provides a rationale for both differential diagnosis and therapy. So this is the case. It's a 63-year-old woman who's got no known medical history, except for some social cigarette smoking many decades ago. So she came into the ED with subacute chest pain, dyspnea, cough, and she's hypoxemic. She notes that over the last 7 days she's been treating herself with a significant amount of chicken soup because it's good for the soul. She has a BMI of 43, and the ED notes states that she came in with bilateral wheezing and lower extremity edema. Her blood work was notable for a mildly elevated BNP, a mildly elevated lactate, and as well she's in some atrial fibrillation with a mild increase in heart rate. She gets the cocktail in the emergency department of IV steroids, inhaled beta agonists, and antimuscarinics because of her wheezing, as well as she receives therapy for community-acquired pneumonia and some diuretics. And this is where the people in the internal medicine side of things laugh, because the ED is really doing the best that they can with incomplete data. Her dyspnea persists, and she has a CT angiogram ordered overnight by the admitting house officer to evaluate for thromboembolic disease. While none is seen, what is seen is a patchy lingular infiltrate with bilateral geographic mosaicism, central lobular nodules, and dependent, actually kind of bilateral apex to base interlobular septal thickening. So you see her the next morning, and she's still fairly short of breath, and she's 89% on 3 liters nasal cannula supplementation. And my question is now, what should you do? And the obvious answer is that you need to obtain an arterial blood gas and calculate an AA gradient. And by that I mean, no, don't do that, because I find this to be one of the most useless exercises in all of internal medicine. I've only ever once seen a hypoxemic patient with a normal AA gradient, and that patient was clearly overdosed on opiates and was breathing about 4 times per minute. The simple act of giving a patient oxygen results in nitrogen washout, resorptive atelectasis. So oxygen in and of itself increases the AA gradient. And when you do calculate an AA gradient, which every hypoxemic patient has, it doesn't do anything to help you narrow the differential diagnosis, nor really help you treat the patient. So I'd like you to forget that equation. So the objectives of this talk is to appreciate the intimate linkage between the cardiac and respiratory pumps and perpetuating dyspnea and hypoxemia. It's going to be more of a mechanistic talk, but I think that it has some clinical rationale behind it. To determine both how the cardiac and respiratory load and how to attenuate the cardiac and respiratory loads in the dyspneic and or hypoxemic patient. I'm going to touch very, very briefly and simply on the chest CT, which are common and which can speak to you in terms of what's going on with the underlying etiology of your patient's work of breathing. So this is my cartoon of the heart and the lungs, and this patient, we'll say, had a lingular pneumonia. And what something like many insults will do, particularly pneumonia, is that they exacerbate the determinants of breathing work. And the 2 determinants of breathing work are airways resistance and, to a great degree, lung compliance. So it as inflammation and edema affects the airways, and secretions affect the airways, inflammatory exudate narrow the small terminal and pre-terminal bronchioles, you increase airways resistance. And to the extent that alveoli are collapsed and inflammatory exudate washes away surfactant, there's definitely an increase in a decrease in pulmonary compliance. And what resistance and compliance do in terms of your airways pressure, your pleural pressure, is they recapitulate the equation of motion. And what that means is basically at any given time, the pleural pressure that you generate, part of that pleural pressure is being partitioned into the amount of pressure that's required to drive gas flow, and that's largely determined by the airway's resistance. And the other portion of that pleural pressure is partitioned into the requirements for generating a certain lung volume, and that's determined by the lung compliance, or elastance. I'll sometimes use them interchangeably. Elastance and compliance are just inverses of each other. And so when the work of breathing goes up, the patient will often, particularly patients who are obese and may have some pulmonary edema, they engage in what's called rapid shallow breathing to mitigate the work of breathing. But the rapidity of the breathing shortens the expiratory time. And when the expiratory time is short in the setting of potentially parts of the lung with high pulmonary time constants driven by high airways resistance, is you start to get air trapping. And this is particularly prominent in the lower lobes and well documented in patients who are overloaded and obese, and for example in cirrhotic patients with ascites. Studies with xenon gas tracers have shown that as these patients expire, the high airways resistance in the lower lobes and the positive pleural pressure on expiration co-conspire to create gas trapping in the lower lobes. And what the gas trapping does is that it traps in air at end expiration, and that starts to generate autopositive end expiratory pressure, which is an end expiratory pressure that's above atmospheric pressure. And to the extent that the auto PEEP can overcome local pulmonary compliance, there can be an increase in volume. Remember, the volume is determined by the transpulmonary pressure, which is the pressure in the alveolus less the pleural pressure, and it's mediated by the compliance of the lung. So if there's auto PEEP that starts to actually increase lung volume, this can lead to hyperinflation. And so the hyperinflation and auto PEEP can feed back, and depending on where it is in the lung, can actually lead to worsening pulmonary compliance if those alveoli are hyperinflated. And there's a really nice review from the autumn of 2011 by John Marini in the Blue Journal discussing mechanisms of auto PEEP and how it can actually be hidden in the lower lobes. So as mentioned, airways resistance goes up, pulmonary compliance goes down. This leads to an increase in the maximal inspiratory pressure, very low pleural pressure, and increased work of breathing. It can also increase the expiratory pressure. But let's focus on the inspiratory pressure. So as you drop your intrathoracic pressure, it's interesting that the fall in pleural pressure in and of itself, there's at least some data to suggest that dropping pleural pressure actually increases pulmonary arterial outflow impedance. And that's what the definition or abbreviation is there. The mechanism by which it occurs is a bit muddy, and the data is also a bit muddy, but there's at least some in the late 70s from a paper in Stephen Sharf's group, I think when they were at Harvard. And what they found was just the simple Mueller maneuver, which is a drop in intrathoracic pressure without any change in lung volume, led to a decrease in right ventricular ejection fraction. And that decrease in right ventricular ejection fraction was accompanied by an increase in right ventricular end diastolic volume. So an increase in right ventricular end diastolic volume in the setting of a decreased right ventricular ejection fraction strongly suggests that the right ventricular end systolic volume increased, which was most likely due to an increase in pulmonary arterial outflow impedance. The drop in intrathoracic pressure also tends to "quote unquote" suck blood in certainly from the abdominal venous beds, and the degree to which the preload increase is partly mediated by the drop in inspiratory pressure, but also by the patient's volume status. And this was modeled after the idea of the West zones in the lungs, which were described by John West in the 1960s, and then adapted to the abdominal venous beds by Takata and colleagues in the early 90s, when they found that if abdominal venous beds were relatively hypervolemic and in so-called abdominal zone 3 conditions, a drop in inspiratory pressure led to a very dramatic augmentation of preload to the right ventricle. So above and beyond the drop in pleural pressure, if there is hyperinflation, as the lung volume increases above FRC, that too tends to afterload the right ventricle as West Zone 1 and West Zone 2 physiology is accumulated. And that's when the alveolar pressure supersedes the pulmonary venous pressure, and the alveolar pressure then becomes the back pressure to right ventricular ejection fraction, or right ventricular ejection. The drop in pleural pressure in and of itself, as it can increase pulmonary arterial outflow impedance, can also increase the aortic outflow impedance. And that is, I think, commonly taught on rounds in the ICU, where the left ventricle is conical and modeled after a sphere, and therefore the modified Laplace's law is applied to it. And medical students and residents are taught that as the transmural wall pressure increases across the left ventricle and the thoracic aorta, then the tension on those things also increases by Laplace's law, and the tension is an approximation of the left ventricular afterload. And the clinical data for this comes from a nice paper by Buddha and colleagues, I believe is how the author's name is pronounced. It's in the New England Journal of Medicine in 1979. And Mike Pinsky was also on that group. I believe the investigation was performed at Stanford. So as the right ventricular afterload goes up and as preload goes up in a patient like ours, this leads, for a very lack of a better term, in right ventricular dysfunction. And by that I mean that essentially blood starts to become trapped in the right ventricle as it can't get out and more of it's coming in. And as the right ventricular volume increases, it starts to lead to ventricular interdependence. And it doesn't necessarily have to result in interventricular shift. It's simply a mechanical phenomenon whereby as the volume of one chamber increases, the compliance of all of the other chambers, including the atria, decrease. But in this, we're speaking about the left ventricle. So this starts to lead to left ventricular dysfunction, or a left ventricular end diastolic decrease in compliance. So left ventricular end diastolic pressure volume relationship curve shifts up into the left, so that for any left ventricular volume, there's a higher wedge pressure. And this will be exacerbated by an increase in left ventricular afterload, because an increase in left ventricular afterload will result in an elevated left ventricular end systolic volume. And so subsequent beats will fill to a higher end diastolic volume, which will then result in a higher wedge pressure. And as mentioned, if there is lower lobe gas trapping and cryptic autopeep, as described in that Marini article in 2011, this can lead to lower lobe elevated juxtacardiac pressures, and this tends to kind of create almost like a pericardial restrictive physiology. And this was described in a nice review in the early 80s, I believe, in Circulation by Butler, entitled "The Heart is in Good Hands." So as the LVEDP starts to rise, you have an elevated left atrial pressure, and this puts the lungs at risk for interstitial and alveolar edema. What interstitial edema does, certainly what hypoxemia does, is it feeds back and it increases the afterload on the right ventricle. Certainly if there's West Zone 4 physiology. West Zone 4 physiology is when the alveolar interstitial pressure supersedes the pulmonary venous pressure and can impair right ventricular ejection. Certainly interstitial and alveolar edema stiffens the lung and feeds back and worsens this aspect of work of breathing, and so too does the airway edema start to increase airways resistance. And these have been described in very classic articles dating even back to the 1950s and 60s that have shown that pulmonary edema increases airways resistance and decreases lung compliance. So you get into this really vicious cycle where you can kind of hop on the merry-go-round anywhere in terms of your respiratory load, and then to the extent that you have poor physiologic reserve in the heart, it starts to increase your afterload and your preload, and you can sort of get into this very vicious cycle. So this certainly applies to a lot of hypoxemic patients that you'll see on the floor, and the question is, well, how do I break this? So before we get to that, I just want to get to the picture is worth a million words, certainly CT scan. And to understand that is a very basic concept of pulmonary anatomy, and that's the secondary pulmonary lobule. And so this is the pre-terminal bronchiole. It typically branches into half a dozen or so terminal bronchioles, which then feeds the sea of alveoli. You can see this, it's completely awash in the alveolar capillary bed. But kind of like the way oranges and grapefruits are subdivided into different segments, the secondary pulmonary lobule is surrounded by this fibrous collagenous matrix, as well as the pulmonary veins in red here and the lymphatics in kind of neon green here. And so abnormalities in any of these things actually can be seen on a CT scan. So it's from a very excellent review in the Journal of Thoracic Imaging, by the way. So how do we see this on the CT scan? Well, this secondary pulmonary lobule that we just talked about can be seen in these polyhedrons here. And what this does is this is a cartoon. This is normal here, and this is the cartoon here. This results in this reticulated pattern, these multiple polyhedrons that comprise the lung. And if you ever forget what the reticulated pattern looks like, you can always just Google a reticulated giraffe, and you see this very beautiful reticulation pattern on the giraffe, and that's exactly what it looks like in the lungs. And so you can see abnormalities in the lungs within the secondary pulmonary lobules here, and you'll sometimes see this written on the reeds, and you can see it with your own two eyes if you look at the images. Central lobular ground glass, central lobular nodules, central lobular tree and bud down here, and if the secondary pulmonary lobules are not outlined, it would look like this as a cartoon on the CT scan. So these down here would be problems of airways resistance, because it would suggest that the terminal and pre-terminal bronchioles are impacted, and this ground glass may actually represent an alveolar problem. Similarly, if the airways, the small terminal and pre-terminal bronchioles are obstructed, on expiration you can get this geographic mosaicism, which was seen in our patient, where certain secondary pulmonary lobules are obstructed and become hyperlucent on the CT scan, and so you get this very interesting pattern, and this mosaicism is suggestive of small airways disease. So let's pretend that this is our patient's chest CT, and this is from a review from a few years ago, and let's pretend there's a pneumonia in there. Our patient came in with the community-acquired pneumonia, and all this chicken soup she'd been drinking has led to bilateral pulmonary edema, but a very prominent interlobular septal thickening pattern certainly can be seen very clearly up here, and there may even be some central lobular ground glass in here. So this is a classic CT scan for volume overload that can be seen with the prominent pulmonary veins outlining the secondary pulmonary lobules, airways thickening, which could be inflammation or certainly edema. Maybe there's some suggestion of left ventricular enlargement, but it could just be the way it's cut here. Nevertheless, it's important to realize that this CT scan clearly demonstrates increased airways resistance, decreased pulmonary compliance, which we talked about. That's the respiratory load, and certainly increase in biventricular afterload and preload. So this patient's work of breathing is very high, and we need to sort of think about when we laugh at other services managing patients who are dyspneic. When I'm looking at a dyspneic or hypoxemic patient, this is exactly how I'm thinking. I'm thinking, what is the resistance load? What is the compliance load? What is the biventricular afterload? What is the preload? What could the problems be there? And then how could I treat it? And certainly my favorite treatment, because it tackles almost all of the problems, is positive airway pressure. So positive airway pressure treats all of the problems that I talked about ad nauseum in the previous slide. So what positive pressure does is it stents open the airway, so it decreases inspiratory and expiratory airways resistance. It improves pulmonary compliance by mitigating air trapping, recruiting collapsed alveoli, and what the improved compliance and decreased airways resistance results in is uniform pulmonary time constants. You can get rid of so-called Pond-de-Luft physiology, and this leads to better VQ ratios as the hypoxemic vasoconstriction goes away and blood can move out of the right ventricle. There's a fall in the right ventricular afterload. Similarly, positive pressure increases the pressure in the thorax relative to the body, so it tends to decrease right ventricular end diastolic volume, and therefore the right ventricular end diastolic transmural pressure. But it's important to note that this probably only occurs when the RV is failing, as in the early 90s, Mike Pinsky showed that the right ventricle operates as a non-stressed chamber. The diminished right ventricular afterload augments or also decreases right ventricular end diastolic volume by promoting blood flow through the lungs. As the right ventricle shrinks, it improves its geometry between the ventricles, improve left ventricular compliance. As the left ventricular compliance improves for any given LV-EDV, end diastolic volume, there's a decrease in the LV-EDP transmural, so the filling pressure goes down. As the filling pressure goes down, there's a decrease in pulmonary edema, which feeds back and improves pulmonary compliance. As the end diastolic volume falls, this lowers the transmural wall stretch by Laplace's law, which decreases afterload. Decreased afterload improves stroke volumes, lowers your end systolic volume, again further improving pulmonary edema, but also augmenting end organ perfusion. As end organ perfusion is improved, the tissues extract less oxygen. And if tissues extract less oxygen, the blood returning to the right atrium has a higher mixed venous oxygen saturation. So then when that blood meets the lungs, meets the new VQ ratios, it will have a higher oxygen content to begin with. And so that plus better VQ ratios ultimately leads to a much better arterial partial pressure of oxygen. So the objectives, again, we went through the linkage between the cardiac and respiratory pumps and how they perpetuate dyspnea, work of breathing, and hypoxemia, the cardiac and respiratory loads and how you can attenuate these in the dyspneic patient, and also very brief words on the CT scan. Please check out these following resources for further reading, and thanks.